So good evening, everyone. And here I am again with another lecture. So let me just share my slides. So tonight I will be talking about feeding difficulties in children. So this is like a continuation of my last lecture on eating habits. And this is where we already have feeding problems in children because uh, of the habits that were not developed properly, early in life, and also due to some other factors, like medical factors and other behavioral and psychological factors. So feeding is a complex process that requires coordination uh, of your nervous system, your oropharyngeal feeding mechanisms, your cardiopulmonary system, your GI tract, and it also needs your uh, craniofacial structures in your musculoskeletal system to function well, in order for it to be effective. So it's like a dance, needs uh, the proper steppings and the proper coordination. And your childhood feeding is really dependent on the relationship between the caregiver and the child. So uh, I'm introducing the concept of your caregiver child diet. So if there is a problem with your caregiver or with your child, uh, childhood feeding may be affected. And it is important that the child gets to eat uh, the proper the required nutrients, in order for him or her to uh, grow and develop well, and remain healthy. And this acquisition is dependent on the child's ability to master certain feeding skills, uh, and this is also dependent on the child's health, or physiology, and also the developmental stage. And I cannot overemphasize the importance of nutrition, because it's through the nutrients that we take, it will spell uh, health or disease, uh, not only in our children, but as they grow older. So it's important for them to receive the adequate amount of nutrients, both macro and micronutrients, and it will depend on the child's age and gender. And we have our Philippine Dietary Reference Intake, as a guide for us Filipinos, uh, on the amount of not only calories, your different macro and your micronutrients, and also water. So we have this as our guide, on what our patients should be getting from their food. And we also have your Pinggang Pinoy, which is a tool that we can show our parents, and also our patients, on what a healthy and balanced diet should be. So we have different Pinggang Pinoys, for your different age groups. And uh, if you have a problem, on the acquisition of your nutrients, this will lead to either deficiency, so you will have undernutrition, and you will be underweight or stunted or wasted, and you can also have overnutrition, so overweight or obese, and that's not good. And sometimes, even if we have normal weight or BMI, we can also have micronutrient deficiencies, no? And this will also result to problems. No? So we call your micronutrient deficiency as your silent hunger. And so our acquisition of nutrients, our ability to feed ourselves, will depend on several factors, even starting prenatally, after conception in our mother's womb, and then the availability of food for the mother, for the baby, for the child, as they grow older, and also eating habits. As I've lectured last time, the importance of developing the right eating habits, and culture, and also external factors like uh, food advertisements, and uh, the availability of healthy foods, in the nearby, are factors that will determine, the child's consumption of proper nutrients. So I've already discussed normal feeding, in my previous lectures, and but tonight we will focus more on uh, feeding difficulties, and also talk about feeding disorders. So a lot of parents will come to us, and tell us that they are having uh, difficulty, in feeding their kids. So almost half of mothers will report that, and fortunately, it's not all of them that are gonna have true feeding problems, and sometimes it's just due to misperception by the parents. So only around a quarter of these kids, will uh, really have feeding problems. And then in among infants who are reported to have feeding problems, uh, a lot of them will continue to have those problems when they grow older. And when we ask parents, as I've said, almost half would report feeding problems, and some of those will just be due to uh, misconceptions, or misperceptions, and then some will be due to milder feeding difficulties, and then only a few will be due to uh, legit na feeding disorders. So when we say feeding difficulties, it's an umbrella diagnosis, or concept, which includes all types of feeding problems, regardless of the cause, the severity, and also the resulting medical and psychological consequences. And it may range, from your mild feeding difficulties like your picky eaters, and also will include those with severe feeding difficulties, like your uh, food refusal, usually seen in children with autism spectrum disorders. Uh, when we say feeding disorders, these are patients, uh, these are conditions in patients, uh, not only presenting with uh, inability to, or refusal to eat sufficient quantities of food to maintain normal nutritional status, uh, but they also have consequences already, because they have like organic, nutritive, and emotional consequences that already impairs their growth. So when you already have impaired growth, no, we consider these feeding difficulties as feeding disorders. And your feeding disorders, no, will have associated medical, uh, feeding skill problems, no, and also psychosocial uh, dysfunctions. Some authors would uh, delineate, no, uh, ordinary feeding difficulties from your feeding disorders, so that they can appropriately plan the appropriate management, no. And so those patients who are difficult to feed but still with normal uh, health, no, they just put those patients under feeding difficulties, and those presenting with uh, health problems already, like your malnutrition, no, they put them under feeding disorders. So when a parent, no, will come to us and tell us that their child is difficult to feed, no, uh, this alone, no, will have to require our attention. So among these patients, we have to get a follow history, and it's best that we use a standardized questionnaire to screen, no, for feeding difficulties. And later on, I will show you an example of that questionnaire. Uh, Aside from a thorough history, we have to get uh, your anthropometrics and determine, no, if there's malnutrition by getting the Z-score. So we have our WHO growth charts to help us with that. And also do a thorough physical examination, no, to detect not only malnutrition but also the presence of other diseases, no, that can result to feeding difficulties. So here's an example, no, of a screening question. This is taken from Young et al. No, and here we ask, no, if there are feeding related problems, no, in the child, no, and how that problems manifest during mealtime, no, if there are presence of underlying diseases, no, and if there's already uh, growth, no, and also if there's delay, no, developmental delay. And we also ask for the child's response, no, during mealtime, the interaction between the caregiver and the child, and also the response of the caregiver, no, to this problem. And also ask for presence of any stress, no, that can affect eating, no, or child feeding at home. So we can also ask questions on feeding history, where the child eats, with whom, and then if the child is already self-feeding, and then the position of the child during mealtime, and also if there is if the television is on, if there are toys, so those are things that we ask our patients. And also we can uh, ask on how much, and what the child eats. So it's better also to refer the child to a dietitian for a 24-hour diet recall, to get a better picture. And then if the child is on a regular food or on special food or formula, and then also ask for consumption of uh, beverages, like your milk, juice, soda, and also ask on particular food, that the child eats, and particular food that he or she dislikes. And also snacking is an important thing to ask. Uh, when the child has prolonged meal time, so more than 30 minutes, if this food refusal, problem has been there for more than a month, there's stress during meal times, uh, and also there's prolonged breast or bottle feeding, and also failure to advance to more solid textures. No? So those are signs and symptoms that suggest feeding difficulties. And when you have dysphagia, uh, signs of aspiration, no, or history of recurrent respiratory tract infection, no, and also when there's vomiting, diarrhea, in the presence of developmental delay, no, and growth failure, these are organic red flags. And behavioral red flags would include a child that's very picky, no, selective, and if there's already forceful or persecutory feeding by the caregiver, no? And when you have anticipatory gagging, before feeding the child, and also if there's presence of failure to try, those are behavioral red flag signs. And after getting the history and physical examination, uh, most of the time we don't really need to request for laboratory workup. But if we suspect concurrent infections, no, and if we want to detect, no, or diagnose particular comorbidities, no, or coexisting diseases that can probably lead to feeding difficulty, then we tailor fit those workups. And after doing so, no, we can uh, classify the child into three groups. No? A child having limited appetite, a child who is selective in his or her food intake, or a child who has fear, in feeding. And we can also categorize the caregiver, no, or the feeder into the feeding styles. No? So we can have responsive, controlling, an indulgent, and a neglectful feeder. And by doing so, no, we can plan properly, no, on how to deal with this child with feeding difficulties. So before we go to those categories, no, I just want to share, some basic feeding principles that we can apply to our difficult to feed patients. So first is to maintain appropriate boundary. No? So it's best that, especially for toddlers, we start complementary feeding, no? To put them on uh, uh, what they call that, high chair, no, and not to carry the child, no, during feeding, and also to avoid distractions like your television, gadgets, no? And as I've mentioned, no, to use an appropriate chair, no, for the child. No? So usually toddlers, so you need a high chair, and for older kids, 5 years old and above, they can sit on a chair, at the table. So you want them to be eating at the table, and we also have to encourage the parents, to feed uh, on uh, on a schedule, so the schedule should have uh, 3 to 4 hour interval, no, between feeding, no. So what I usually tell my uh, parents, is to uh, give breakfast 6 o'clock to 8 o'clock, snacks 9 to 10, lunch time at 12 to 1 p.m. and then afternoon snacks at 3 to 4 and dinner at 6 to 8 in the evening. And at least there's at least 2 hours interval between feeding. So this approximates your gastric emptying time. So we don't want to give food in between feeding so that the stomach is empty just before feeding, and this will ensure hunger, so that your child will eat. Okay, so if there's something there that's on your stomach, that will limit the child's appetite. And more or less, this schedule will follow the usual eating schedules, as the child will go to school and even uh, uh, become adults, later on. So this is the usual eating time, that we get. Okay, and then also when feeding, it's important that the parent or the feeder, uh, maintains a neutral attitude, uh, but smiling. Okay, so feeding with a smile. So we tell them that they should not get anxious or angry, or overly excited, because this will disrupt uh, the feeding, of the child. And it's also important that feeding times should not be more than 30 minutes, because the attention span of children, is around 15 minutes, and more than 30 minutes it's already too long for them. And some kids would avoid eating, because the usual meal time, will be more than 30 minutes. And then it's also important to tell the parents, to give age appropriate food, or serving, so sometimes, there's conflict, between uh, expectation and reality, so the child's stomach is smaller, than the adult parents. What I usually tell the parents, is to check on the size of the fist of the child, so that's it's more or less estimates the size of their stomach. So they should not expect the child to eat like no, to eat the amount of food that the child eats, is more or less lesser than uh, what they're eating. Okay. So also the feeding sizes, I would tell them to use yung smaller size na mga spoons, and also to wait for the child to finish swallowing the food, or chewing the food. Okay. And then if the gonna introduce new food, they should introduce one at a time, so that the child doesn't get startled, or caught uh, unaware. Okay, and for times when they introduce new food, sometimes the child doesn't accept immediately, so the child spits out the food, or does refuse to eat, they should try to give it around 5 to 15 times, before they give up, especially among infants and toddlers. And then for toddlers, we can also encourage them to use their own utensils. And another thing to avoid, is excessive wiping of the face especially during eating time. This is quite sensitive part uh, sa, among children, and they don't really want their mouth to be constantly wiped, so this will distract them during eating time. So I tell them just to clean the face, after uh, each meal time na lang. So first up, no, are children with limited appetite. So sometimes, no, the parents, no, is has some misconceptions, no, with their child's appetite. So as I mentioned, no, so some parents would expect their child to eat uh, a lot of food, no, just like them, just like an adult. So it's important to tell them that the child's ability to uh, uh, eat, no, food, no, is smaller than the adults, no? So what in among these parents, no, it's important to emphasize that uh, there should be acceptance, no, on the child's kaning ability to eat, no, consume amounts of food. And then we can also show them your growth charts, so they can see that their child is growing well. No? We can also compute for your mid-parental height. No? Sometimes there's some concern that the child is not growing well. No? So we can show them that there's no stunting, no, by computing for your mid-parental height. And then review the basic principles, no, feeding principles that I've just mentioned to them. Sometimes we get a child with limited appetite who is very energetic, no, or active. No? So this is sometimes known as your non-organic failure to thrive or your infantile anorexia, no, or nutritional growth retardation. So we have here a child that's very energetic, active, no, and sometimes is more interested, no, in playing and talking than eating. And these are child more of ADHD, no, refuse to be seated, no, especially during meals, no, and they just eat a small amount because they just play, and play. And in some of these kids, no, there's already failure to gain weight adequately. And in most of them, no, we can detect conflict between the child and the feeder, no. So what we tell these parents, no, is uh, it's important to recognize and to respond appropriately to the child's uh, hunger and also satiety, no. So it would be best, no, if there's appropriate feeding schedule, and also that the parent must be model, no, on healthy eating, and also should have that healthy eating habits, no, so that the child will follow them. Okay. And in very difficult to control children, no, so what the parents can do is to give a mealtime time out. So nang they just sit there, no, and stare at the child, no, and then if the child is misbehaving, okay. And in children who are energetic and active but with limited appetite, no, it's important to give our supplements, no, nutritional supplements, while we are correcting uh, these behavioral problems. And then we can also have apathetic, no, or withdrawn child. So, medyo ulawon na child, silent lang in the corner. So this child is inactive, no, or disinterested, no, with their environment and also with eating. No? So there's poor eye contact. No? They don't talk that much, no, and in these children, no, they can also be malnourished. And what's usually observed, no, is the child and the caregiver might have depression, no? And there's also poor interaction between the caregiver and the child. And what we advise, no, is to provide adequate nutrition, uh, telling them ano, no, by showing them Pinggang Pinoy, and also encourage interaction, no, between the child and the feeder. But sometimes if the feeder is also problematic, we would suggest that an experienced feeder at home, usually the lolo or the lola, uh, be the one to feed the child. And also tell the parent to uh, learn the appropriate feeding skills. And then if this child really goes into malnutrition, it's important that we do early intervention. Sometimes these children may need hospitalization if they are severely malnourished. And then by doing physical examination, we can also detect presence of certain organic diseases that can cause limited appetite in a child. And this can be structural diseases, so may mga malformations, and then even some of them having gastrointestinal, cardiopulmonary, neurologic, and even metabolic conditions. So sometimes manifestations are just subtle and easy to miss, and then in some patients, they complain of pain, or dysphagia during feeding. Uh, of course, the management, is dependent on the organic disease. Okay, so we have to uh, treat the disease, and also at the same time plan, on how to give proper nutrition. So in patients who have an impaired ability to eat, because of either structural defect, or inflammatory defects sa GI tract, or even poor feeding skills, because they have a neurologic problem, they may need enteral and hopefully not parenteral nutrition, just for nutritional support. And in these patients, it usually requires multidisciplinary approach. How about children with who are very selective in their food, So first is neophobia. So neophobia happens when the child reaches the first year after the child completes the first year of life, at 1 year old. And this is usually self-limiting. This is the time when the child is usually anxious, with new sensation, including food. That is why we want our kids, to develop proper eating habits and to be exposed to different tastes and textures, before they reach 1 year old. And that's how important, a proper complementary feeding, is for children, because once they reach 1 year old, so neophobia sets in, and this will sometimes cause problems. So for patients with neophobia, by constantly offering the same food, at a time, uh, around 8 to 15 times, until they get used to that food, so that's how we go about neophobia, so constant lang na giving of that food until maanat na siya, matolerate na niya. Sometimes you already have real picky eaters. So picky eaters are children who consume fewer kinds of food, and with constant repetition, or constant giving of a certain food, uh, this doesn't seem to work much well with picky eaters. And picky eaters usually grow and develop normally. They usually consumes naman adequate amount of calories. So that's why they don't really get malnourished. But sometimes they do get overweight or fat, because especially if the food that they're consuming are kaning calorie rich foods, when we do in our investigation, no, we can detect some family discord and also coercive feeding. No? So, ginasuhulan nila ang child just to eat. No? And among picky eaters, no, there's also higher incidence of anxiety, depression, aggression. And it's not only the child that has problems, it's also the feeder, no, with behavioral problems. And for picky eaters, no, the start, no, we can make use of sauces, no, just to hide certain food, and then gradually can introduce more amounts of that certain food, no, until they get used to it, no. And then also the parent should be again a good model, no. Uh, so we cannot expect the child who is picky eater, no, to eat a healthy balanced diet if the parent or the feeder doesn't eat a healthy and balanced diet. So very important to emphasize that to the parents. And then sometimes we can suggest that the child helps in cooking and the preparing the food, and also the use of bento food boxes, no, with colorful food and ng attractive arrangement, no, that can sometimes help in children who are picky eaters. But in the extreme end, no, we also have a child that's very highly selective. So they already have what we call as your food aversion. So they refuse to eat a certain category of food, uh, especially if they have the same taste, smell, or appearance, no, or texture. So this is already a feeding disorder, no? And the diet, no, is limited to just around 10 to 15 kinds of food lang, no? And if this is not addressed, no, normal development of your oral motor skills, no, is affected. And in a lot of these kids who are highly selective, no, they are also easily distracted with loud noise, bright lights, no, and even some touches, no, on the skin. So parang autism, no. Actually, uh, a lot of them have autism, no. So I have a lot of patients with autism, and most of them are very highly selective, no, with their food intake, no. And if you have a child that presents with kanang sensory food aversion, no, or very highly selective, and then they also have like kanang problems sa social interactions nila. So this may be the first signs, no, of autism. So how do we go about with these children? Maybe it's best that we refer them, no, to developmental pedia, no, and also behavioral therapists, and also um, ng speech therapists, no, oral motor therapists can help. So uh, feeding management, no, or the type of feeding approach, no, maybe in very intensive, no, for this patient. So we can what what the dietitian can do to help, no, is to do food chaining. So um, for this child to slowly tolerate certain food groups, no, especially katong important na mga nutritious food groups, no. So the dietitian would usually start with appearance or texture na usually familiar or usually what the child eats, no, and then gradually uh, ng change, no, the food preparation of the certain food group, no, until hinahinay ma-tolerates the child, no, or ma-familiar siya. So it takes a lot of effort, no, with these children, especially if they have autism. Okay. And then some patients who are also selective in their eating have organic diseases, no? Organic problems. So they have developmental delay, no? And then some of them are hyposensitive or hypersensitive uh, to their responses on food, no? And some of these patients with delay also have delayed oral motor skills, no? That can affect the type of food that they can tolerate, no? So patients with motor disorders, no, they can uh, put food in their mouth, no, accept food, but there's difficulty in swallowing both liquid and solids. For sensory disorders naman, uh, in older kids, no, there's usually anticipatory gagging. So pag butang pa lang sa food or pagdala pa lang sa food ng gag na sila or gamurag ga-try sila na sani, no, na kanang mag-vomit. So mahadlok ang parents, no. So and then usually when these kids, no, they can tolerate mga liquids, milk, but pag solid food, marag mo refuse na sila, mag-gag sila. So I've also seen some patients, no, with this. And this can require also multi-specialty referrals, no, uh, in patients with kaning gagging, anticipatory gagging, no, what we could do is to do hunger inducement. So medyo kwan siya kaning uh, that medyo extreme siya, no. uh, but while we do hunger inducement, no, so yan strict yun sa feeding schedule, no, and then kailangan strict yun ta na dili ta mo give in sa katong kailangan anong gusto sa patient, no. But this will really have kanang dapat na ay guidance sa kanang mga sa dietitian and sa mga behavioral therapists. And while we are doing this interventions, no, it's very important to supplement these kids, no, with your multivitamins and minerals, and also sometimes kinanglan o kanang milk na on the sides, no, during snack time siguro para lang they get to have adequate calories and they don't be pushed further into malnutrition. And then sometimes for children, no, who are hyposensitive, no, medyo dili kay mayo ilang face, medyo bland ang ilang face, no. So maybe seen in mga patients, neurologic patients, no? Giving food, no, with strong flavor, no, can help stimulate can appetite. How about kids with phobia, no? Fear of feeding. So sometimes, no, infants with excessive crying, di ba, what they advise really is not to wait for this feeding, infants to cry, no, before you feed them. So you have to take note of their feeding cues, because when they start crying, no, breastfed or bottle-fed infants, no, may be difficult to feed na. So sometimes these parents, no, would think na na I fear of phobia ang kid, no, with feeding, because they resist breastfeeding or bottle feed na once they're already kanang naga-wild na sila, no, naga-cry na sila. So this not really real phobia, no. So it's just important to tell the parents, no, to be aware of the feeding cues, no, and to feed the child before he or she goes into tantrums na. Okay? And also for uh, children who have excessive crying, no, we have to investigate, no, why they're crying. Sometimes it's not really because they're hungry, no, because sometimes they have other conditions like colic, no, And then also some kids lang yun, no, they have disordered state regulation, no, nagsaputon lang yun sila, no. So in fortunately naman for these kids, no, they have normal weight naman and nutritional status because they receive adequate naman amount of calories. So it's important lang to reassure these parents, no, and also to tell them, no, with regards to feeding cues and kung excessive yun ang crying, no, or discomfort sa this patient, no, is to investigate, no, what's causing the discomfort or anxiety of this child. For true feeding phobias, it can be due to painful feeding. So here, your child, no, when they're awake and then when they consciously swallow food and milk, no, mag-cry sila or mag-stop sila feeding. Then sometimes the parents will notice na, dok, medyo mas usog siya mag-feed kung patulog siya, no? Or while tulog ang bata, dede sa bibiron. So, I've also had some referrals, no, with sa ngayon na klase ng mga patients. And in these kids, no, with feeding phobia, no, usually there's something that triggered, no, kaning ano ng fear in these kids. So sometimes can forceful feeding, no, or maybe the caregiver, no, has some behavioral problems, no. So this will progress, no, if this is not addressed. This will persist, no, as the child grows older. So it's important, no, when you detect them during infancy, no, is to identify, no, what's causing the anxiety or pain, no, in these kids, no, and then do the conditioning. It's very difficult to do. Easier said than done, no. But establishing sleep feeding schedule, no, so siguro at the start, no, siguro advice nimo is kung patulog ng bata, kaya mag-feed, no? Pero dili siya pwede na this will ano kanang uh, persist na behavior, no? Kailangan hinihinay ng we have to do the conditioning. Okay? So we also have to ask, no, for the feeding environment, maybe daghang kay distraction or there's something that's causing anxiety sa bata, no, sa feeding environment. And also even the feeding equipment, the bottle siguro, no, maybe may bad experience ang kid, no, parang baby, no, na-choke siguro siya at one time, so medyo gakadlok na siya sa bottle, no. So in some of these kids, no, labi na kung ano pa, they're on milk feeding, maybe an early transition to cup feeding, no, or solid foods may be required. In older kids, we call this ano, no, functional dysphagia or choking phobia, no, or phagophobia, no. So usually they gag or choke or vomit when they eat. Okay, so a lot of times, no, you have a parent that's very controlling, no, or do forceful feeding, and if this goes on very long, no, prolonged siya, you can already have malnutrition. So how to deal with this, children with feeding phobia? First is reassurance sa parents, but you may need to give anxiolytic medications not only to the child but even siguro sa parents. Behavioral intervention can be of help, positive reinforcement or cognitive behavioral therapy. Sometimes we may need to refer to a psychiatrist. Maybe this child has a psychiatric disorder or condition. And sometimes we may need to do endoscopy, no, especially if there are organic, possible organic causes of phobia, no, or or fear in feeding, especially if there's pain every time the child feeds. And while we're doing our intervention, again, supplementation is also advised. No? In patients who have GI motility problems, no, sometimes in patients who are on prolonged tube feeding, and then when we try uh, taking away the tube and start oral feeding, no, these kids may have some fear, no, of feeding, and also in some neurologic or neuromuscular disorders, no, wherein that there's uh, choking, no, or bad experience during feeding. So the child will have refusal to feed. And it's important really for children with who is suspect of feeding phobia, no, to rule out organic causes, no, and to treat once we identify these organic causes. So sometimes when we take away the tube, some hyperalgesia occurs, no, with prolonged NGT. That's why with what we advise, no, pag more than 2 months naka-NGT, kung pwede ma-transfer sa gastrostomy tube or PEG. And these patients, no, again, hunger inducement can help. Also desensitization, no, the help of your oral motor therapies, no, and also gradual introduction of food, no, in a non-threatening way, no, will help these kids with feeding phobia. And then aside sa kids, no, we have also to diagnose what kind of feeder our caregiver is. So we can have a responsive, indulgent, neglectful, and controlling feeders. No? What we want really is a responsive feeder. No? So these are feeders na to encourage eating, no? And then also respond adequately, no, to the child's any wants or needs, no, but not too overly responsive, because they become indulgent feeders, by doing so. So they have to give the right amount of nutrients, no, then interact with their child. So that's what we want, responsive feeders. Itong mga parents, no, na sobra na lang pabigay, no, pabigyan ang child. So these are indulgent na parents, no. Sali gusto ka unong sa child, hatag-hatag. Ang extreme sad is ang katong neglectful feeder. So bahala na lang bata kung siyang gusto ka unong. So wala na ipaki ang parents kung nutritious siya or not, no. So kung bahala kung kakaon adequately or not. So dili wala sila ipaki. So and then on the other end of the spectrum ang katong overly controlling parents, no? So kananglan masunod lang gid ang gusto nila, no. Sometimes they do forceful tactics, no, or scare tactics, no, or pressure tactics, no, to their kid. So how can we detect the feeding styles, no? We can ask some questions, no? So we can ask how anxious the parent is about the child's eating, and then ask them to describe what happens during mealtime and what their response is, no, when the child doesn't eat. So with that, no, we can more or less can classify the parent as either responsive, neglectful, indulgent, or controlling na parent. And usually, no, when we ask these questions, mga neglectful parents, no, they give a vague answer because they don't really know what's happening to their kid. And then controlling parents would tell you that they force feed, no, their child. Indulgent feeders, no, are the parents that beg, no, or plead the child to eat, no, and then most of the time they end up preparing a special food, no, or getting the favorite food of the child, just as long as the child will eat. So for responsive uh, feeders, no, or responsive feeding style, no, children would tend to eat more fruits and vegetables, no, and dairy products, less junk foods, and they usually have a normal nutritional um, status. No? Controlling parents, no, or controlling feeders, no, the child usually has um, poor uh, satiety, no, and hunger cues. They usually eat a lot, no, because they are force feed, no. So atong medyo obese or overweight, you just remember how your parents were feeding you. Masing threaten mo na ano, masuko si Papa Jesus kung linuhot doon ang food. So children with controlling parents, no, tend to eat less fruit and vegetable, and there's a pretty good chance that they are either underweight or overweight. Indulgent parents naman, on the other hand, will have kids that consume less nutritious food because usually ginahatag lagi din sa gusto sa kid, no? And these kids tend to favor mga uh, fat-rich or high-caloric food, no? Mga sweets, no? And they have an increased risk for obesity. And for neglectful kids, no, they have a pretty good chance to be either very malnourished, no, or very obese. No? Feeding disorders, no, as I've mentioned, are would include the mga kids with feeding difficulties but already have problems now with their health, with their nutritional status. And this is because they have their impaired oral intake, no. Uh, they will have ng they will have difficulty on getting enough uh, nutrients, no, from food and liquids and even water, no. So how do we know that they're getting enough? You can make use of your PDRI, no, your nutrition, your standards, no. So different age group, different gender, will have different caloric and macro and micronutrient requirements, and we can refer them to a dietitian, no, so that we can get a better picture on if the child is eating adequately, and also to check on age appropriate skills. No? So, syempre, if you have an older kid who still doesn't know how to feed him or herself, no, or there's a problem with texture, no, so these are kind of signs of feeding disorder already. We have to wait at least 2 weeks man lang, no? Because we have to rule out acute illnesses, and your feeding disorders will not include uh, eating disorders, no? Like your anorexia nervosa, your bulimia, no, because they already have psychiatric problems, no, and some body image disturbances. And your feeding disorder, no, should result, no, to obvious disability. So there's limitations activities and also certain restrictions when it comes to activities. So we can either classify them into acute or chronic. If less than 3 months, it's acute. More than equal to or more than 3 months, it's already chronic. So there's a proposed criteria for feeding disorders, pediatric feeding disorders. So you have here disturbance of oral intake, no? Lasting more than 2 weeks, inappropriate for age, and they can either have medical dysfunction, nutritional dysfunction, and then they can also either have feeding skill dysfunction and psychosocial dysfunction. No? And sometimes, no, you don't have these dysfunctions, but there's cognitive process na consistent with an eating disorder, and this eating disorder would lead to malnutrition, and in the absence of uh, cultural uh, reasons, or kanang lack of food. Kadipit man ang food, then di man gibawal sa culture, pero wag sa gakaon. So we can also classify them into diagnose them having pediatric feeding disorders. So examples lang on medical conditions that belongs to pediatric feeding disorders. You have your GI tract diseases, oropharyngeal anomalies, inflammatory diseases, motility disorders, and then sometimes your airway and lung diseases, like your chronic lung diseases, would present with pediatric feeding disorders because of prolonged hypoxia. So, as some congenital heart diseases, and also included here are your patients with neurologic impairments, like your cerebral palsy. Nutritional conditions, like patients who are overweight, underweight, obvious micronutrient deficiency, dehydration, and also sa dietary history, there's restrictive dietary diversity, so mga picky eaters. Also, patients with feeding skills can be diagnosed with feeding disorders if they have impaired oral and pharyngeal sensory and motor functioning, and if they have delayed feeding skills, and in patients with psychosocial impairment, mental and behavioral health problems, even psychosocial dysfunction, like ang patient mismo picky eater, or the grazing, or there's feeding aversion, and also the feeder has inappropriate feeding strategies. We can label them all having pediatric feeding disorders. So why label them as pediatric feeding disorders? So the main reasons for coming up with this criteria is the authors wanted a more kaning sensitive na kanang early detection of feeding problem, and then if kung detect na it's already a feeding disorder, proper referral can be made, so that proper management can be done, so in order to avoid complications like your malnutrition, and we know mas delayed ang management, so it would be a little bit harder na to address or to reverse, especially kung actually mga behavioral problems. We want to catch them early and to manage them early. So what we want in these patients is to correct what the problem is, to give adequate nutrition, and also do other management that can help, like for example, giving certain medications or formula if needed. So one of these medications that we can give is your dibencozide. So your dibencozide is a coenzyme, a biologically active coenzyme of your vitamin B12, and then that is usually seen in muscle tissues. And what it does, it helps in the metabolism and absorption and integration of your amino acids into your muscle tissues and your DNA. Okay, and so it's an important coenzyme in the activation in the activation of the incorporation of your amino acids to your protein molecules in your muscle tissues. Okay, and it also helps, in the repair of your body tissues, and also in the utilization of your protein intake. So what we have here, no, if we take protein, no, so where does your protein come from? No? Usually, sa mga meat sources, no, from milk, and also from plant sources. No? And once we digest them, no, into the basic building blocks, which are your amino acids, no, these are absorbed in your small intestine, and some of these amino acids are used for energy utilization, although your protein is the least naman sa utilize for energy, uh, or energy use, no. We usually use first your carbs, your fats, and then last is your protein. But some of these proteins, no, get to just roam around in your bloodstream, and it's with the help of your debencocyte, no, that they get integrated into your muscle tissue, your lean body mass. So they say also works as an appetite stimulant, because uh, as more amino acids are integrated, no, into your muscle tissue, so you will have parang a reduction, no, in the protein levels, no, or amino acid levels in your bloodstream, no, or reduce amino acid pool, no, in your blood, and this will stimulate, your appetite center to look for more protein, no, or more food. So in a way, no, it affects appetite. Okay, so your Debencocyte naman has several studies, no, among preterms, among infants, and even among older kids, no, showing that there's an increase in their body weight, no, after at least a month man lang na treatment with your Debencocyte. Okay, so hopefully, no, in your patients who are having feeding difficulties, no, you can also make use of your Debencocyte. So before I end, no, I would just like to emphasize that your pediatric feeding difficulty is a relatively common problem, perceived or real. No? So a lot of parents will come to you and tell you that their child is not eating well. So it's important to determine which is perceived, which is mild, and which are feeding disorders, severe feeding disorders. So that, and then classifying them or requires a systematic approach, and hopefully uh, the approach and introduced by Dr. Kersner, no, will help us, no, classify our patients into uh, limited intake, selective intake, and then also patients with phobias, no, and also classify our uh, feeders, no, into either responsive, indulgent, neglectful, or controlling, so that we can more or less plan, no, on how to deal with this feeding difficulty in our patient. And sometimes management will require involvement of different people, no, specialists like me, gastroenterologists, mga developmental pedia, speech therapists, no, dietitian. So the earlier that this patient is managed properly, no, the better it's going to be for these patients with feeding difficulties. So with that, I end this lecture. If you have any questions, I will be glad to answer them. Thank you.